Hello, everyone, and welcome to our Pediatric Neuro-Critical Care webinar that is offered by the World Institute of Critical Care and Emergency Medicine. And we have our one-year fellowship online in critical care, pediatric care. And today we have great speakers and moderators from Egypt, Saudi Arabia, Canada, USA, and I'm just going to give you a brief introduction and summary about our Pediatric Critical Care Fellowship that is accredited by the American Association of Continuing Medical Education for 96 credit hours and structured as 3 modules, 16 weeks each. Each week will have lectures, journal club, MCQs, clinical case scenarios that is delivered via a smart platform. Our fellowship board members are from all over the world, from Pakistan, from USA, Canada, South Africa, Saudi Arabia, Egypt, and more. And we are very particular about the diversity of our program, not only for the board member, but also for our fellows. So far, we have fellows from 28 countries who applied to this one-year online fellowship. And because we know that our retention rate is very low when it comes to teaching tools through one-way education by lecture and reading, we try to use at least audiovisuals, demonstrations, discussion, and to improve your clinical practice and also help you to get engaged with bidirectional educational tools. Again, this is 1-year online fellowship structured as 3 modules, and each module is 4 months. It's real education, not only based on webinars or seminars, but it's mainly dialogue between the tutors and the fellows. And we will have a lot of MCQs, evaluation and assessment, critical thinking and appraisal, and we are gathering a panel of expertise. It's a wholly online fellowship program, very unique flagship program, and there will be weekly lectures recorded and also monthly webinars and virtual workshops and video conferencing. So all the fellows will receive the scientific material within the smart platform on a weekly basis. So all the educational materials will be released every Monday, 8 a.m. And the fellows will have the freedom to navigate throughout the scientific contents during the whole week, and they need to turn in their assignments and tasks before the end of each week on Sunday night. All activities and assignments are monitored in the platform, and there will be a quantitative and qualitative evaluation, not only based on how to answer and to get the correct option, but also on engagement and the learning curve of each fellow. Our first module will be focusing on the different kind of shock, causes, classification, criteria, pathophysiology of shock, nutrition in critically ill patients, point of care ultrasound in acute settings, and infectious diseases. The second module will be dedicated for different kind of organ dysfunction, start by respiratory critical care field, cardiovascular critical care, then the renal critical care. The last module is focusing on neurocritical care, traumatic brain injury, endocrine, metabolic disorders, oncologic, and gastrointestinal disorder. Upon completion of this program, you would anticipate to be an expert in the field of pediatric critical care, and also you'll be graduating from a trainee and the mentee level to a trainer and the mentor level. And of course, you're going to receive certification for completion of the fellowship from the American Association of Continuing Medical Education. As I mentioned, today we have very special and experts speakers. And here is our today's agenda. So Dr. Mahmoud Bashir is going to give you samples of the fellowship materials. Then Dr. Ali Said is going to give you some information how to deal with confused and unconscious child. Dr. Turki Al-Atibi is the organizer of this webinar, and I really appreciate and thank him too much for this. It's a great effort. So he's going to moderate the session with Dr. Anna and the discussion. Then Dr. Bij Burgess is going to give us a talk about how to deal with increased intracranial pressure and the cranial monitoring, pressure monitoring and management. Dr. Bassam Al-Bassam is going to help her to answer the question and moderate the session with her. Then we'll have the closing remarks and take-home messages by Dr. Turki Al-Atibi. Again, all of this activities, all of this education has no values except if we put it in clinical practice. And the great aim of education is not the knowledge itself, but the action. So we are targeting to improve our patients' outcome. Our children are very special and unique, and they are vulnerable, and we are trying to help to improve the standard of care and our patients' outcome. This is our ultimate goal. With that, I'm going to stop by here, and I'm going to let Dr. Mahmoud Bashir to share his screen and show us some of the fellowship materials. Dr. Mahmoud is consultant of pediatric critical care. He did his fellowship in United Kingdom in BICU, and he was a consultant in Oman for several years, and now he is back to Egypt and practicing. So I'm very sure that he will give you very informative lecture about the materials that you will see in our fellowship.
Thank you, Dr. Amr. My name is Dr. Mahmoud Bashir. I'm a pediatric consultant, currently practice in Egypt. Today, I'm taking you through samples of material for our teaching program. First, I would like to share this short video how to browse or navigate our website, because some facing sample issues with that. So you will go to wiccem.org. Then you will find our teaching programs here, Pediatric Critical Care Fellowship. Once you navigate down, you will find video as introduction for our fellowship. Then the handbook. In this handbook, you will find all the details you will need to know more about the teaching program and the weekly activities and so on. This is our board members and at last registration link. So learning methods in this fellowship will be weekly online lectures and monthly webinars, case-based discussions, self-paced modules and quizzes, and weekly journal clubs. This is an example. So it's a traditional way of teaching, recorded lecture. This is example of the lecture we will give, and we'll go through the lecture in a traditional way. You will have it in a recorded method through our platform. But as we know, this is not enough. And we are sure that lectures as a part of education, giving very less information and using multiple methods of teaching will help us a lot in education. That's why we are following this with case-based discussions and multiple choice questions, like in this case, related to the topic for sure. Here we have week about analgesia and sedation and conscious sedation in ICU and ER. So if you have a 4-year-old child brought to the emergency department with a displaced forearm fracture after fall from swing, he's otherwise healthy with no significant medical history. The orthopedic team plans to perform a closed reduction. You are asked to provide a procedural sedation. So somehow the cases will be in a similar way, details about clinical data, the weight, and others, which help you to take a decision about the answer. The child vitals are okay, and he's fasting for 3 hours. The question will be, which is the following is the most appropriate sedation for nitrous oxide and dexamethasone. Once you answer the question, you will get an automated score and performance report. Here the answer will be IV ketamine, and for sure you will get why is this answer, followed by some explanation and some basic information also about the topic and references. Weekly journal clubs are very important also. So we will use recent review and tutorial article. You will get a PDF related to this for sure, followed by assessment questions too. Here is an example. You will use the same topic for sure, and we choose a relevant article and most recent too. Following this, you will have similar questions and case-based discussions. Here we have a 3-year-old child for an elective MRI under sedation. The child has history of well-controlled asthma, uses salbutamol inhaler approximately once per week, and has no hospitalization or exacerbation in the past year. Physical examination and vital signs are within normal limits. There is no comorbidities, and the child developmentally appropriate for his age. Which is the most appropriate ASA physical status classification for this child? You can try to answer with us too. ASA 1 up to 5. Following this, you will find the correct answer and why this is the correct answer for sure. Thank you. Thank you, Dr. Amr, for the introduction too.
Thank you, Dr. Mahmoud, for this presentation. Okay, so welcome everybody for our Neuro-Critical-Care challenge and best practice webinars. Me and 2 of my colleagues who are board members of Pediatric Critical Care Fellowship will moderate this scientific webinar. Me, Dr. Turki Al-Otaibi, pediatric intensivist, King Fahd Military Medical Complex. And also with me, Dr. Anna Guans, who is consultant pediatric intensivist in Children's Hospital, and she is also associate professor in Western University, London, Ontario, in Canada. And Dr. Bassam Al-Bassam, who is consultant pediatric intensivist, work in King Faisal Specialist Hospital and Research Center in Riyadh, King of Saudi Arabia. Our first speaker is Dr. Sayyid Ali, who is a friend of mine and my teacher also, and my colleagues, who is a senior consultant pediatric neurologist in King Fahd Military Medical Complex. He will talk about few challenge cases about unconscious and child. And Dr. Ali, welcome for the our scientific webinar. Can you start?
Okay. Thank you, Dr. Turki. Thank you, everyone, Professor Amr, for giving me this opportunity to share with you. This is important webinar. Do you hear me? Is it okay?
Yes. Yes, voice is good.
Okay. So I will try to use this 30 minutes to give you just a flavor of what we are dealing actually with such children in our hospital. Our hospital is a tertiary care center where Dr. Turkey actually he joined maybe more than 10 years back from Miguel in when he came back from Canada. Yeah, and everything was changed actually in our hospital. We have a very nice BICU, well equipped and well staffed actually. So we do receive children with who are confused and then with encephalopathy because our catchment area is a big one. So we are serving more than three hospitals actually, the naval base and the air base, and this is our hospital. So it's a sort of military hospital with a lot of families there. My talk will be composed of introduction, then
Can you
definitions.
upload your presentation, Dr. Said?
Yeah.
Upload the presentation. Share the presentation.
It's not showing, just didn't show.
Share.
Ah, yes, okay. Now, here.
Okay,
Is it
thank you.
okay?
Yes.
Yeah,
Make
okay.
it bigger.
So I can enlarge the screen, or
No,
is
you
it
can
like that?
press. Make it full. Huh?
Okay,
It is-
full.
Yes.
Is it okay?
Good. Excellent.
Okay.
Okay.
So briefly about the examination, important investigation and management, cause it, and then I will give case scenarios. I will start by actually case scenarios. This is an 8 years old boy who is known to us. He was diagnosed as Angelman syndrome, and he had an epilepsy. Then he was stable actually on treatment, was getting sodium valproate. And then maybe after 1 year or so, he came with his mother. The main complaint was confusion and unresponsiveness. Otherwise, he was walking, but with a bit clumsy gait, but no history of recent seizures. Then when we did the EEG, it was actually showing, it was an X-ray recording, it was showing an epileptic encephalopathy. I will show you the EEG. So we admitted him to our BICU and he received IV anti-seizure medication, that is IV sodium valproate. His EEG was showing a high amplitude delta, that's generalized discharge spike and wave and body spike complexes. And this, for us, this is consistent with non-convulsive status epilepticus. Here, just working clinical criteria for non-convulsive status in patients with non-epileptic encephalopathy modified from Bizinski in 2013. He said that an increase in prominence of frequency of specific EEG features when compared to the baseline with observable changes in the clinical state. And then you will get the improvement once you give these children IV anti-seizure medication. And then he looked here at the some EEG series, and some children they showed left hemisphere abnormalities. Some of them right hemisphere. They could see also generalized discharges or left blades. This I will discuss it later. It's what's called periodic lateralized epileptiform discharges, which sometimes it's not pathognomonic, like we do see it in patients with herpes encephalitis. And then they can see alpha coma, theta coma, bear suppression, or even triphasic wave. This child actually his EEG was at one stage short triphasic phase. A nice paper from Nicholas Append. This is about non-convulsive status epilepticus in pediatric intensive care unit. Another paper, electrographic seizures in pediatric ICU patients. And so the non-convulsive status can present like altered mental status, confusion, coma, lethargy, memory loss, only can be all speech disturbance, unusual behavior, anxiety, agitation, or delirium. Circumstances in which you consider the non-convulsive status, if the child clear or persistent clinical change in behavior, cognition, or autonomic function in the context of fever, acute neurological injuries, specific epilepsy syndrome like Dravet. We do have one child is admitting frequently, Dr. Turk is aware of him. And then myoclonic aesthetic epilepsy, malignant migrating partial epilepsy, Lennox-Gastaut, Panatopoulos, and non-progressive encephalopathy. This is an EEG also from recording from a child with Lennox-Gastaut syndrome, showing the slow generalized discharge in comparison with absence. This is a very interesting case, which is very rare in my practice over more than 30 years. First time to see typical absence status. The girl came with confusion, admitted over the night. Then the registrar saw her, and then they said this could be an encephalopathy, and then they did a lumbar puncture, and they started her on acyclovir. So the next day, we dig in the history, and then nothing was there. The nurse observed some fluttering of the eyelids. And then when we did her EEG, it showed typical absence. Also, we gave her IV sodium valproate was okay. But that was interesting. So EEG is a powerful tool in assessing confused children with recent alteration in level of consciousness. Quickly, what about encephalopathy? Encephalopathy is not a diagnosis, but a descriptive form or a syndrome of global brain dysfunction with diffuse differential diagnosis. It has a high morbidity and mortality if it's not recognized. So in this talk, I will present a structural approach to assess and investigate such children. Brief definition, what do you mean by fully alert? It's aware of self and environment. So if the child is confused, is not fully oriented, but is able to maintain arousal or wakefulness normally, lethargic. This is difficulty in maintaining the aroused state and obtunded, responsive to stimulation other than the pain, stuporous, responsive only to pain. If the child is comatose, here is unaware of self and environment. But this is, you'll be confronted with these terms. But I mean, the most important one is the objective assessment is the Glasgow Coma Scale. Coma, this is a state of unresponsiveness in which patients are not aware of their surroundings, usually lie with eyes closed and have no sleep-wake cycle. So acute encephalopathy is defined as impairment of consciousness of acute onset. The Glasgow Coma Scale usually below 11 and with duration of more than 24 hours or longer. The consciousness is maintained by a normal function of the brainstem reticular activating system, what they call it here, if you can see it here, this one, and its projection to the thalami and the cerebral hemisphere. So non-specific finding that this encephalopathy implies mild, moderate, or severe CNS dysfunction, a symptom of underlying. So it could be either due to infectious process, metabolic disease, drug toxicity, other systemic conditions. Clinically, encephalopathy can present with depressed or altered mental status, confusion, change in personality, irritability. So I'll try to give you about the causes or etiology. This is infection, para-infection, autoimmune, trauma. Trauma is accidental or non-accidental. Seizure, toxins, metabolic, hypertensive, hypoxic, ischemic, or hemorrhage. So this is in brief, infection like meningitis and encephalitis and so on. Autoimmune, we do see cases with ADEM, and then now also some cases of autoimmune encephalitis, trauma, seizure, toxins like drugs, heavy metals also, then carbon monoxide, metabolic also, then hypertensive, hemorrhage, malignancy, then hypoxic, like near drowning, near sudden infant death syndrome, and so on. So we have to have a focused history about the duration of symptoms, vomiting, whether there is headache, fever, convulsions, period of fluctuation of consciousness, trauma, and ingestion of medications like alcohol or recreational drugs, presence of medication in the child's home. Then the physical examination also has to be focused. This is just to concentrate on the CNS examination. Always, I'm telling the resident, if the child is comatose, try to elevate his eyelids to see. Sometimes if you have a tonic deviation of eyes, this child might having a subclinical seizure, okay, or electrographic seizure. You will not see it clinically. Then fundi are very important, whether this is child abuse or this is imbabiledema. And then the pupillary also size is very important, size and symmetry. Later on, I think Dr. Burgess is going to discuss about increasing tachyon pressure, so I will not go into that. Hypertension is very important. You should do forelimb pressure. This is just to show you early babyledema, and this is an advanced one. Investigations also, you take initial investigation, blood gas, blood glucose, liver function test, ammonia, toxicology screen, and so on. Lumbar puncture, of course, you do it if you suspect encephalitis or meningitis, or if you suspect autoimmune or whatever. But you have to be careful if the child clinical condition is not stable, so there is a contraindication to avoid herniation. CSF, you send it for count and differential protein, and CSF also BCR for viral and bacterial. 2 weeks back, Dr. Turkey has a case which the BCR CSF showed meningococcemia, actually, to our astonishment. Although the child, yes, he was febrile, and but we thought initially it is a sort of encephalitis, but it proved to be meningitis. So it's very important. For autoimmune, also, you have to go to send for autoimmune antibodies. This is just to show the importance of neuroimaging, the importance of the EEG, and then quickly about the management, infection, para-infection, autoimmune, usually steroids, immunoglobulins, plasmapheresis. Now it's very important. We do, Dr. Turki, if you remember, we had a recent case also with transverse myelite. We used to do that very frequent for him. Now, if encephalopathies, especially acute necrotizing encephalopathies, we have a family who they come in coma, and sometimes we used to give them missile bread and IVIG, but now actually plasmapheresis also is mentioned. So trauma, and then seizures, toxins, hemodialysis, metabolic and dietary restrictions, and so on. We have in Saudi Arabia also what's called biotin responsive dystonia. This we can give them IV thiamine. And then I will give you just for the sake of time. This is a case of 11 months old ex-preterm. Actually, he admitted to our hospital before as bronchiolitis. Then, if you see there was a sort of fractured ribs were missed. To be admitted again, actually, he was in bad shape, history of seizures and shallow breathing, and then intubated and connected. And then this case showing actually here subdural hematoma, fractures, and retinal hemorrhage. Unfortunately, it was a sort of a non-accidental injury or child abuse. So this is like shaking baby syndrome. Should always be aware of that. The child can come in with all that. So it's a subdural hematoma, evidence of bone fracture, retinal hemorrhage, and retinal detachment. You can stage also the hemorrhage if they had the trauma inflicted in several times. You can get it by the MRI also. Then case 3, during one cold winter night, father came late and he found two of his children sleeping beside fireplace, and they were watching the TV. He tried to wake them, but were unresponsive. He rushed to the hospital to the ER. He came. This was, and then they were in deep coma. Actually, one of them is saved. The other one, he had this abnormal MRI. Later on, he developed dystonia, and he was like a movement disorder. This was due to carbon monoxide poisoning, which is a silent killer actually. Another case, 11 months old infant, he received herbal medicine for teething. Nowadays, they are not using it. This is maybe more than 15 years back. Then he came with Caesar's coma, macrocytic hypochromic anemia. Another child also history of BICA, convulsions, coma, signs of increased intracranial pressure and babyledema. And this is showing lead lines. So it was lead poisoning. Before it was common, nowadays it's not that common. But always you put it in your mind. Also, if you have a child, this is a child who had a history of travel to Pakistan, and he came with fever, convulsion, coma, hypoglycemia, and thrombocytopenia, and then proved to be malaria. If you see the ring forms of this cerebral malaria. Another case is very interesting, like the one I told you about the status absence. This is an 8-year-old boy. He came with continuous vomiting, actually, and convulsion, although he was not febrile, but it was encephalitis-like picture. If you remember, Dr. Turki, at that time, Dr. Suleiman was the resident, and he did for him a lumbar puncture, and he started on acyclovir. So the next day we did an EEG, and it showed occipital spikes. So this is a very also important syndrome to know. This is benign childhood epilepsy with occipital spikes, or Penaltopoulos syndrome. It comes with autonomic symptoms, and very important to recognize, because once you give anti-seizure medication, the child will be okay. And then case 7 is a 2-year-old girl. She had a history of fall from a table, and then she came with drowsy and crying. Just to show you, this is accidental injury. That one I showed you non-accidental. This is accidental. So she clearly she had 6-nerve palsy, and then when we did the skull X-ray, it showed the linear fracture of the day. So this is just a simple head trauma showing. Another important, this is we do see them either iatrogenic or and then this is a 3-year-old girl also sustained upward deviation of eyes, mutism, restlessness, agitation, behavioral disturbance, pupillary dilatation, and then she had like a dystonia or backward flexion of the neck. She received antiemetic. This is called oculogaric crisis. We see it with many medications like this one, metoclopramide, or nowadays, because a lot of children with autism are receiving these antipsychotic drugs, haloperidol also can cause it. Then another case interesting, referred to me from another hospital, 8-year-old girl presented first to the ENT with diminution of hearing, and she was confused actually. And that was her MRI, initial MRI. Okay, the CT scan was showing very tiny hemorrhage here, subcortical, but the MRI actually was showing this enhancement over the temporal area. So her BCR was positive for herpes simplex, and her EEG always. This is actually blades, the one I told you. This is bilateral epileptiform discharges, very peculiar to the herpes encephalitis. Okay, then case 10, a 6-year-old girl, history of fever and upper respiratory infection, confusion, deterioration, and then coma. So she was intubated and ventilated. This is the one I told you. Her sister was having admitted to the hospital before with similar illness. And this is called acute necrotizing encephalopathy. This is a rare but potentially life-threatening neurological condition. And the three sisters admitted to us, the first one, actually we were confused initially. We thought this is Adam, but they have a very peculiar MRI findings, especially the lesions are very symmetrical. And then this three girls, they have a genetic actually a mutation, a certain gene. Then we publish a big series, acute necrotizing encephalopathy of childhood in multicenter experience in Saudi Arabia. This is the one I told you now, beside missile bread and IVIG. You could use also plasmapheresis to improve the outcome, actually. This is again to show you the same, the MRI. And then autoimmune encephalitis, we do see some cases. Now, this is an 8 years old also girl. She came with presented with history of fever and headache, psychological disturbance. She was crying and making not her usual self. Okay. And then she started to have seizure and confusion. Her MRI initially was normal, actually, not showing anything, but later it was showing some changes. CSF was showing pleocytosis, and then we sent for NMDA receptor antibodies. The EEG was showing extreme delta. If you are lucky, you will get it. Extreme delta brush. This is very peculiar in the encephalitis. Another case, 10 years old boy, history of upper respiratory tract infection weeks ago. Then he came with drowsiness and decreased level of consciousness. MRI revealed features of demyelination and CSF analysis. So here are big, large, confluent lesions. Sometimes even can give mass effect. So this is ADEM, the acute disseminated encephalomyelitis. Sometimes you have to differentiate it from MS. But here, usually the sensorium is affected, whereas in MS, I have seen it's not affected at all. The last case is before that. So there is a criteria. So it's a polyfocal neurological event with a suspected demyelinating and inflammatory cause, unexplained encephalopathy. Then you have an abnormal findings in the brain on MRI during the acute phase. The MRI findings large, poorly demarcated lesions involving the white matter and possibly gray matter involvement. No new lesion in the MRI. This is just to differentiate from MS, because MS, this is not MS, usually is a relapsing sort of demyelination disease. The last case, this is biotin responsive basal ganglia disease. We have seen a couple of cases also. Usually these children, they come with features of acute encephalopathy plus dystonia. And then you can have either basal ganglia enhancement or the brain parenchyma, cortical and subcortical enhancement. And the good thing about it, if you know it and you recognize it earlier, you could give the child biotin and then IV thiamine. Very nice response there. If you miss it, the child will have consequences and morbidity. So this is biotin thiamine basal ganglia disease, very common here. This is just to show you one series from non-traumatic coma in India. So you could, due to cardiorespiratory arrest, 21 case, virulent meningitis, epilepsy, poisoning, 16 cases encephalitis, cerebrovascular accidents. So each country has different actually prevalence of things. Hepatic encephalopathy, 5. We used to see Ray's syndrome, nowadays not common, gastroenteritis. So in conclusion, the encephalopathic child is a pediatric emergency that can present a diagnostic dilemma and carries with it a significant morbidity and mortality. Good management can limit the extent of longer-term damage. It is important that all children who may be involved with all clinicians who may be involved in children with altered mental status, they can use a systematic approach that allowed them to form a differential diagnosis And thank you. I hope the time. Thank you very much.
Thank you, Dr. Ali, for this nice presentation and I thoroughly reviewing the confused or not responding or encephalopathic picture child. Now we'll go for a question, 2-3 minutes for the question. For the attendees, unfortunately, we'll not be able to hear from you. If you have any question, you can write it in the chat or the question and answer, and we will ask the speaker. First question, Dr. Ali, about, EEG. EEG is a tool, and I wanted to comment about this, is not only for detecting epileptic discharge. It can help in a patient with encephalopathic picture. Can you talk about this?
Yes, of course, yes. It is not only in detecting seizure, but it is important also in cerebral function, monitoring cerebral function. As you know, sometimes the child will come with acute encephalopathy. What we'll see maybe generalized slowing or depressed actually trace. Even some children, their condition will deteriorate till they will get brain death. And then we have a brain death criteria for that. But I mean, the most important thing about the EEG in the ICU setup is the monitoring of the electrographic seizures, because some children, these children are confused or comatose, and clinically you might not observe any sort of seizure. But when you do the EEG or you monitor them, you will see discharges. These children you have to treat. Then again, the tuberculosis involving us in status epilepticus. So sometimes we will give we want to put these children in pair suppression phase, if you remember. Then by using sometimes propofol or so. So we rest the brain also. This is monitored by the EEG. So we'll give them, we put them in pair suppression for 24 hours, sometimes 48 hours. And then after the improvement, he removed his sedation, and then we do we go back to the. So the EEG in the BICU is very important, actually, very important. We are using it in many tools. And in ICU, they have what's called the automated or the augmented BICU. This is it's different from the conventional one, but that's it. Okay.
Okay. Doctor, there is a question. Let's continue to what you are saying. There's a question from one of colleagues. His name is Khalid. Non-convulsive status epilepticus. Any specific criteria to catch it early? Non-convulsive status epilepticus.
Usually, these children, they are known to be epileptic. They have an epilepsy before, and then not necessary to have seizure, but this confusion. Actually, they're coming change in behavior and alteration of consciousness. Like the one I told you, that child actually was walking. But when you see the EEG, I thought, how is this child still walking around, not in coma or anything? The only usually we see it in children who are having known to have epilepsy. It can come طبعا initially with a new case, like in usually cases who are known to be epileptic, and then they are coming with abnormal behavior. And this is usually in epilepsy with the severe ones, the epileptic encephalopathies, the one I told you, the Dravet syndrome, the Lennox-Gastaut, and so on.
Thank you, Dr. Ali. There is two questions. I need so short answer, please. There is one of our colleagues, Isra, in limited resource country. What we have only the CT scan and a lot of cases of unexplained encephalopathy. Can we do anything more? I mean, CT scan, or if it is only limited resources, is the CT scan can help?
Yeah, CT scan can help actually. Actually, two or three of the cases initially, Adam actually was sent from an ENT surgeon because the child was having abnormal hearing. Then when they did the CT scan, it showed like what do you call it? in motion enhancement. It was the lesion was there, and then when we did the MRI, it showed the edema and everything. Then the lumbar puncture is important also. طبعا the EEG and the lumbar puncture.
Okay, physical examination. Okay, investigation, LP and CT scan. Last question, because just brief answer, Dr. Ali, because we'll go to the second speaker.
Yes.
The role and successful of plasmapheresis in autoimmune neurological disorder. I mean, role. What plasmapheresis is doing? Is it removing something? Or...
Yeah, it is removing the antibodies. Actually, before what we have this missile steroids and then IVIG. But still, these children, they did not improve. And you can use plasmapheresis not one session. Sometimes you can go up to 15, 20 sessions actually to improve them. Do you remember the last days? Yes. So it's
okay.
important.
Thank you, Dr. Ali. We have to stop here because of the time. And then now I will let my colleagues, Dr. Gwenzi, to present the second speaker. Thank you, Dr. Ali, for very nice presentation. And I think
stop share.
Yeah, stop share, please. And the second speaker will start. Okay, and Dr. Gwenzi will take the lead for the...
Thank you very much for that excellent talk. Next, we have my colleague, Dr. Paige Burgess. She's a pediatric intensivist in London, Ontario, Canada, and as well as assistant professor at Schulich School of Medicine and Dentistry at Western University. Dr. Burgess completed her medical degree at the University of Toronto with subsequent pediatric and pediatric critical care fellowships at the University of Alberta, at Alberta Children's Hospital in Calgary, and then Stollery Children's Hospital in Edmonton, Alberta, Canada, respectively. She is a very passionate and very talented educator, which you will soon find out, with leadership roles in pediatric critical care medicine in terms of pediatric residency education, as well as our competency chair for our own fellowship program. She's a special interest in innovation and simulation-based training, and when she is not taking care of patients or teaching, she can be found chasing program functions. She will be speaking to us about increased ICP monitoring and management. Thank you, Dr. Burgess.
Thank you so much for that kind introduction. I'm hopeful that you can all see my slides and the audio is okay. Perfect, great. So I'm very grateful for the invitation from the WICE to come and speak to you today regarding increased intracranial pressure monitoring and management. I do have a somewhat ambitious list of learning objectives to try to get through today. We'll spend a little bit of time focusing on some of the core physiologic principles that underscore cerebral hemodynamics and our management of increased ICP. We will talk through a brief differential diagnosis for increased ICP, as well as the different monitoring techniques we have available to us. We will also talk a little bit about some ancillary tests that may be more available in resource-limited settings, such as head imaging, optic nerve sheath diameter, and transcranial Doppler studies. And then finally, by exploring a clinical case, we will review the initial stabilization principles and ICU management of patients presenting with increased intracranial pressure. So to start first, we'll review the basics of cerebral hemodynamics. And it's really difficult to talk about cerebral hemodynamics and have a good understanding without first diving into the Monro-Kelly doctrine and truly understanding the essence of this very basic but important principle. Essentially, the Monro-Kelly doctrine tells us the relationship between intracranial contents and intracranial pressure. So like any fixed space, the more stuff we pack into that space, there is going to reach a limit where we've reached capacity. And if we want to put anything else inside, we're going to have to use force or pressure to shove that extra matter inside the space. So the cranium is a fixed space, and eventually, as you increase the intracranial contents, you're eventually going to see increased pressure within the cranium. This diagram here depicts that nicely. We have our normal state where typically inside the cranium we have venous blood, arterial blood, the brain parenchyma itself, as well as cerebrospinal fluid. There's then a state where we say have an extra piece of matter within the cranium, let's say a brain tumor that's taking up space, and the venous blood and CSF are able to compensate to a point where some of this extra fluid is being displaced outside of the cranium in order to make extra space for this new mass. And this results in a normal or preserved intracranial pressure. Unfortunately, though, when we reach the decompensated state, we've essentially outstripped our body's abilities to compensate for this extra mass inside the cranium, where no more venous blood or CSF can be displaced, and therefore we see a sharp uprise in intracranial pressure. And that's depicted in this graph here, where we have intracranial volume increasing on the x-axis, and then pressure on the y-axis. We see that there's a compensatory phase, and then suddenly we outstrip our ability to compensate, and our intracranial pressure shoots up astronomically. So why does this matter, this start up stroke and intracranial pressure? And it really all comes down to the syndrome of herniation, which is what I do, or what I spend a lot of my time in the ICU with my brain injured patients trying to prevent. So herniation is essentially forced displacement of brain tissue through or around relatively fixed or firm structures within the brain. So this can occur around the falx or through the foramen. Complete herniation means that this brain tissue is displaced, and there is no chance that you will be able to recover that brain tissue because you've essentially completely choked off all of your arterial blood supply and venous drainage, which leads to tissue ischemia and death. And unfortunately, that is going to increase your patient's morbidity and mortality astronomically. So in order to ensure that we're protecting the brain as best we can and trying to avoid herniation syndromes, our management is hinged upon the principle of maintaining a safe and adequate cerebral perfusion pressure. So this one physiologic principle is going to underscore the vast majority of our management of patients with high intracranial pressure. Cerebral perfusion pressure represents essentially the gradient at which blood flow is going to enter the cranium. So we have our mean arterial pressure, which is the force driving arterial blood into the cranium to perfuse the brain. And then we have our intracranial pressure, which is essentially the resistive forces that are resisting blood from entering the brain. And of course, in order for there to be flow within the cranium, there has to be a gradient between the two. So CPP is equal to our mean arterial pressure minus our intracranial pressure. Now, of course, if we have an astronomically high CVP, which is our venous drainage pressure, the CVP is going to become more important than the ICP. So there is this asterisk here to indicate that caveat that our CPP, if we have a CVP that is higher than ICP, our CPP will need to be taking the CVP into account. The other concept around cerebral hemodynamics that's important to understand, which underpins the vast majority of our management in these patients, is that of cerebral autoregulation. So you can see here, this line or curve represents a normal or uninjured patient. And you can see that on the y-axis, we have cerebral blood flow, and on the x-axis, we have blood pressure. And the beautiful thing about cerebral autoregulation is that the brain has this very sophisticated mechanism to maintain a steady state of cerebral blood flow across this very wide range of blood pressures. So this is why when we go to sleep and our blood pressure, say our systolic is 90, on a diastolic of 50, we don't wake up with a hypoxic global ischemic injury. And it's also why we can go for a run or go to the gym and increase our blood pressure up to 140 on 80 and not present with signs and symptoms of a hypertensive urgency or emergency. So cerebral autoregulation is that mechanism by which we preserve the steady state or amount of blood flow across a wide range of blood pressures. In our neurologically injured patients, particularly our traumatic brain injury patients, there is going to be a subset of patients who lose their ability to autoregulate. And instead, we're going to see more of a diagonal line between our blood flow and our blood pressure. Thereby, even a small increase in our blood pressure will lead to an increase in our cerebral blood flow. And conversely, a small decrease in our blood pressure, even within a normal physiologic range, will be seen as a reduction in our cerebral blood flow. So again, this is important to understand when we talk about management of ICP. Over on the right-hand side here, you can see a couple of other variables in terms of how they relate to cerebral blood flow as well. So MAP, which we just talked about here in the blue line, and then we have our partial pressure of oxygen and partial pressure of carbon dioxide. When we have a patient who is hypoxemic, the brain's response in order to try to increase oxygen delivery to the brain is to vasodilate the vasculature to increase the cerebral blood flow. This in turn will increase our intracranial pressure. And you'll see that the cerebral blood flow plateaus at a partial pressure of oxygen greater than about 60 millimeters of mercury. The opposite we see with the relationship between blood flow and our partial pressure of carbon dioxide. Our hypercarbic patients are going to have cerebral vessel dilation and increased intracranial pressure. But if we hyperventilate these patients and we drive down our PaCO2, we will have a resultant constriction of our cerebral vasculature, resulting in decreased cerebral blood flow and decreased ICP. So now that we understand some of the physiology underpinning increased intracranial pressure, we'll talk a little bit about the differential diagnosis. Dr. Ali did a beautiful job presenting a much more thorough differential diagnosis than I will as a simple intensivist. But whenever I receive a phone call or have a patient that's presenting with any neurologic concern, I seem to automatically default to this very simple mnemonic to formulate a scaffolding for my differential. And that is DIMS. So D stands for drugs. In the acute care world, not so common in terms of a cause of high intracranial pressure. In emergency, however, you might see Accutane or isotretinoin-related increased intracranial pressure. I stands for infection and inflammation, so thinking about our meningitis, encephalitis, autoimmune encephalitis, or abscesses. M stands for metabolic, so thinking about cerebral edema secondary to our hyperammonemic crises or severe diabetic ketoacidosis. And S stands for structural. And again, I just think back to what are all the normal structures in the brain? Venous blood, so could there be a large venous clot? Arterial blood, so could there be a large bleed or aneurysm rupture? There's the brain parenchyma itself. So could that be edematous after having a traumatic injury or a hypoxic ischemic injury? And then the CSF, could there be like an obstructive hydrocephalus causing increased ICP? And then thinking about, is there something foreign, like a brain tumor, that could be inside the brain that's not supposed to be? So how do we detect high intracranial pressure? And the challenge here is that recognizing increased intracranial pressure early is very challenging because the signs and symptoms are very nonspecific. So you can imagine if you're seeing a patient in the emergency department who's had a 4-day history of gastroenteritis, they may present with a lot of these signs. They might be irritable. They'll have vomiting and poor feeding. They might be a little bit sleepy or have altered level of consciousness. So it's really important to keep increased intracranial pressure on your differential diagnosis and have a very low threshold to do further workup to either confirm or rule out your suspicion. If you have a child with an open fontanelle, a tense or bulging fontanelle may be appreciated. And then finally, cranial nerve 6 palsy is one of the more specific signs, one of the first cranial nerve signs that we see in high ICP, as it has the longest course outside of the brainstem from its exit to the brainstem to its target organ. Now, the late findings are a little bit easier to detect, but unfortunately, they're late and therefore are going to result in your patients potentially having a worse outcome. So late findings of increased intracranial pressure would be our Cushing's triad. So Cushing's triad consists of systolic hypertension, bradycardia, and irregular respirations, and then pupillary changes. I find a lot of the time when I'm speaking to my medical students and residents, they tend to think that the only pupillary changes we can see in herniation syndromes is a blown or fixed and dilated pupil. However, we know that that's just not true. Subfalcine herniation can actually present with no pupillary changes. Central herniation can result in these small fixed pupils. A uncal herniation leads to that classic fixed dilated pupil. And then tonsillar herniation can lead to more so midpoint fixed pupils. So when you suspect high ICP, how do you diagnose it and monitor it? And really the gold standard is an intracranial pressure probe. This here is an example of one of the different varieties that's on the market, but essentially the principle is all the same between different companies. And that is that you have a small caliber microfilament that is inserted either into the brain parenchyma, the subdural space, or into one of the lateral ventricles. And this produces a continuous waveform and pressure reading. One of the benefits of the ICP probe is, again, the continuous monitoring that it allows. It's also relatively easy to insert. Often in our unit is done at the patient's bedside. The drawback would be that this is invasive and therefore there's an infectious risk that's associated with ICP probes. The transducer cannot be calibrated once it's in situ. And there's a phenomenon called baseline drift, whereby the accuracy of your intracranial pressure monitoring can be decreased over time. As I mentioned, the ICP waveform is produced by a pressure probe, which can be another piece of useful information for the clinician in terms of detecting instances where brain compliance is compromised. So typically in normal instances, we have P1, which reflects our arterial pulsation, P2, which is a gross reflection of brain compliance, and then P3, which is our dicrotic wave associated with the aortic valve closure. And typically we see P1 being the highest. When we see compromised compliance and impending ICP crisis, we see P2 start to rise and become more significant than P1. And in more serious of cases, P1 and P2 can almost meld together and form a single wave. So a P2 to P1 ratio, or P2 greater than P1, is suggestive of high ICP. And then an elevated time to peak can also be another sign. Another way to continually measure our intracranial pressure is through an extraventricular drain, which I'll refer to as an EVD. So the benefits of an EVD is that we're able to transduce pressure and waveform. We can actually have some therapeutic drainage of CSF, which could be a way to decrease our intracranial pressure. And we can re-zero this appliance after it's placed. The drawback is that this is more of a large caliber tube and therefore more invasive than an ICP probe. And therefore the infectious risk and the risk of bleeding is higher. Particularly in an instance where you have high ICP, your ventricles could be compressed, and therefore this can be very challenging to place. And management, particularly bedside management by nursing staff, requires quite a bit of specialized training, as there is risk of over drainage of CSF. And then finally, you can't drain CSF and transduce the pressure at the same time, which requires clinicians to toggle back and forth between these two different functions. What are some different ancillary tests that we can use when we suspect high ICP? one of which would be a CT head. So there are various signs that we can look for to indicate potential high ICP, which would be sulcal effacement, effacement of our basal cisterns, compression of our ventricular system. And then, of course, if we see frank herniation on the scan, that will indicate there's high pressure intracranially. And we can see here this series of images are from the same patient, the left taken first and the right taken 8 hours later. This patient presented with severe cerebral edema secondary to acute liver failure. And we can see in the first image, there's some preservation of the sulci and basal cisterns. And then unfortunately, 8 hours later, everything looks almost completely effaced. This meta-analysis was published in 2019, which again shows that there really isn't any particular feature on our CT that is sensitive or specific enough to consider this an adequate test for diagnosing ICP. So invasive ICP monitoring, either through a probe or an EVD, is still the gold standard for diagnosing intracranial hypertension. One of the up-and-coming potential diagnostic tools would be an optic nerve sheath diameter. So using a simple linear ultrasound probe, which you place over the closed eye, you're able to calculate the width of the optic nerve sheath with various upper limits of normal for our different age categories in pediatrics. And this paper reported for an optic nerve sheath diameter greater than 5 millimeters, in terms of its correspondence with an ICP greater than 20, there's a pooled sensitivity of 97% and specificity of 86%. So not too bad. Transcranial Doppler is another tool that may be helpful, again, in more resource-limited settings. So using an ultrasound probe, we interrogate the middle cerebral artery, which produces a waveform, and calculate something called the pulsatility index. This study shows that there's moderate correlation between the intracranial pressure and the pulsatility index, specifically within the first 24 hours of injury. So again, this might be something that's a helpful screening tool to help you either advocate for ICP probe insertion or transfer to a center with more resources available. And here we can see the flow pattern that is produced with our transcranial Dopplers and how it changes with our CPP decreasing. So here we see preserved flow in diastole, which progressively decreases as our CPP increases. And then finally flow reversal at the end of, or in diastole when CPP is quite low. So that brings us to stabilization and management of high ICP, which I will form around a case that I based loosely around a patient I recently took care of in our own unit. So this is a 16-year-old male who suffered a motocross accident, was initially GCS3 on scene, and then was quite combative. 90 minutes after his event, he arrived in our department with a heart rate of 72, quite hypertensive, bradypneic, and a GCS of 4. His right pupil was 5 millimeters and fixed, and his left pupil was 3 millimeters and sluggish. So again, you can see that this patient is showing, unfortunately, late signs of increased ICP and herniation syndrome. So when your patient, you have concerns for acute herniation, this is really the recipe that I teach to all of my residents and medical students. The first is to use gravity as your friend and elevate the head of the bed, trying to promote more venous drainage from the cranium to decrease intracranial pressure. The second is to hyperventilate the patient. And again, this all comes back to understanding this curve in terms of how our PaCO2 influences cerebral blood flow. So you are decreasing your cerebral blood flow as a means to decrease your intracranial pressure and hopefully reverse the partial herniation. And you hyperventilate you titrate that to the pupillary response. The third is hyperosmolar therapy, so either using hypertonic saline or mannitol for their osmotic effects. It's important to remember that mannitol will have an osmotic diuresis effect, and therefore you need to be very careful that you're managing the patient's fluid balance as to ensure they're not becoming dehydrated during this process. And then finally, you need to get this patient ultimately to a scanner to consider potential surgical intervention. So this patient went to the scanner. You can see here a skull fracture and an associated epidural hematoma on the right-hand side, and a contusion here in the right temporal area. So they went to the operating room, had their hematoma evacuated and an ICP probe placed, and was transferred to us post-operatively. And again, as I mentioned, I spent the next, I believe, 9 days with this patient obsessing over this equation. So the cerebral perfusion pressure equal to the MAP minus the ICP. And my main goal was to keep this CPP within a healthy limit. When we look at our brain injury guidelines, they say the absolute minimum is 40 for a CPP. I'd say this is more appropriate for a infant or young child. So a CPP for a young teenager, I would aim closer to about 60. So how did I do that? Well, again, thinking about our equation for our CPP, we can either decrease our ICP or our CVP, whichever is higher, or we can increase our mean arterial pressure. So to keep a healthy MAP target, you're watching your intravascular volume status and using vasoactives to augment. And then you're ensuring that your ICP is within an acceptable range. Again, you do this by promoting venous drainage, keeping the head midline and the head of the bed elevated. You're draining CSF if you're able to through an EVD. You're utilizing your cerebral blood flow hemodynamics in terms of the response to oxygen and carbon dioxide partial pressures. So our target PaO2 is 90 to 100 and CO2 of 35 to 40. I'm keeping the child's metabolic activity nice and controlled by targeting a normal temperature, managing any agitation with sedation, and any pain with analgesia. And if the child is shivering, I use neuromuscular blockade to stop that. And additionally, from a cerebral edema standpoint, I'm doing my best to prevent that by keeping a generous sodium target greater than 140. If there are concerns around increased CVP, you need to be aggressive in terms of managing that. So be cautious with your vent pressures and aggressively treat pneumothorax. So that's the first part of my job. The second part of my job in managing these patients is to avoid any secondary injuries to that already vulnerable brain. The two biggest evils that we'll encounter will be hypoxemia and hypotension. So we need to do everything that we can to stress the importance of maintaining our targets within these healthy ranges. We also know that hypoglycemia can cause a secondary injury to the brain, and we're seeing more and more that hyperglycemia and the free radicals as a result can cause oxidative stress. Therefore, if the patient has persistent hyperglycemia above 11 millimoles per liter, you have reason to start an insulin infusion. We aggressively treat seizures or prophylax with antiepileptic and treat fevers as well. And then finally, we were keeping a very close eye and correcting any coagulopathy and ensuring that there is no significant anemia. So for this patient, he spent the first 4 days of his admission deeply sedated, intubated, ventilated, cooled, and on a hypertonic saline infusion. On post-admission day 5, we were able to wean off the saline infusion. And on post-admission day 6, we were able to liberalize our temperature targets and PCO2 targets. The following day, we weaned sedation and removed the ICP probe. He was successfully extubated. And then on post-admission day 9, he was transferred to the general pediatrics ward. 9 days later, he was discharged home with outpatient rehabilitation services in a reasonable neurologic state. So with that being said, I've just put my learning objectives back here. I understand that's a complete whirlwind, but I'm more than happy to entertain any questions. and open the floor to the moderators. Thanks so much for your attention.
Thank you very much for that excellent presentation. There are a few questions related to your talk. I think there was some curiosity about recommendations for sedation in, in a patient with traumatic brain injury. There was the question of thiopental. I wondered if you could elaborate on recommendations for that.
Dora Anna, can you increase your voice, please? Because some audience cannot hear you very well.
Oh, I apologize. The question was around sedation of patients in TBI, if there's specific agents. There was a specific question as well about inquiring about thiopental.
So in terms of the traumatic brain injury guidelines in pediatrics, the initial sedation recommended or analgesia sedation combo is a narcotic and a benzodiazepine to start. In our older children, we often will use propofol as well, which is, I would say, more commonly used in adult circumstances. However, with the pediatric population being at risk of propofol-related infusion syndrome, we need to be very cautious with its use in our population and ensure that if we are using it, we're monitoring for PRIS. So certainly the place to start, if you're following the guidelines to a T, is a narcotic and a benzo combination. Your question around dexmedetomidine is an interesting one. I personally don't use it unless I have an ICP probe, and that is because the side effect of dexmedetomidine is decreased heart rate. And of course, we're watching these patients like a hawk for increased intracranial pressure, and one of our signs of Cushing's is bradycardia. So if we don't have a reliable way of monitoring the ICP, sometimes dexmedetomidine can just cause more anxiety and concern for increased intracranial pressure that is not actually, or that is more so related to drug than to actual increased ICP. In terms of thiopental, it is not available in Canada, so I can't say that I have any experience using this drug. But I'm more than happy to open the floor to other moderators who may have access to this in their setting.
Yeah, we had limited, a number of years ago, we had limited access to it. I think it's the same in the United States. It's due to the lethal injection that's used in the US, not in the Canadian system. But it can be very effective to decrease ICP, but it's seen more as a refractory adder. I don't think, I've never in my experience seen it added as a sedation piece, but more for a patient with refractory ICP, and that's once everything else has been maximized. And any other moderators welcome to add in. I'm going to throw in that vein. There was a question about when do you give seizure prophylaxis with a presenting patient? And another one, and there's a number of questions around 3%. So how much can you give? When do you stop? When do you consider a bolus versus continuous infusions?
Sorry, your last question was, or your last bit of that around infusion versus
boluses. So, guidance, like what is your approach to actually, you giving 3% in boluses? What's the maximum dose? When do you give continuous infusions, and what kind of clinical scenarios?
Yeah, certainly. So around 3% specifically. So I would certainly give a bolus if I have a concern about herniation syndrome, where I'm doing my very best to try to get this patient to a CT scanner to get information that will potentially inform definitive management. So I use it very much so as a rescue therapy. I would also be more aggressive in terms of giving larger quantities or, shorter infusions, so kind of a pseudo bolus, so to speak, if I have a patient with high ICP and or is at risk of high ICP and is hyponatremic or not meeting that target of minimum sodium of 140 millimoles per liter. In terms of using a continuous infusion over a longer period of time, I would say that if I'm struggling with maintaining an acceptable ICP and CPP despite multiple other interventions. So for instance, my patient is already sedated and ventilated. I have all of my ventilation, oxygenation targets in place, and I am still struggling despite that adequate sedation. Then I would think about adding on an infusion and trying to drive my sodium a little bit higher than 140. So first I would start with pushing it up to 150, but we know that we also have to be careful because if we have prolonged hypernatremia, I believe the guidelines say a serum sodium over 160 for more than 72 hours is associated with DVT. And then if we keep our serum sodium over 170, then we get into trouble with thrombocytopenia and anemia secondary to bleeding. So it's very much so, again, a therapy that I add on or layer on top of my kind of base neuroprotection package when I'm continuing to struggle with ICP management.
And what about anti-epileptics? Do you prophylax?
Oh, yeah.
Do you not prophylax?
The guidelines do not have a very strong recommendation around this. My personal practice is that if I have a severe TBI, they all get a minimum of 1 week levetiracetam seizure prophylaxis. And again, that's just risk versus benefit. Levetiracetam is a relatively well-tolerated drug with few severe side effects, and you know the potential risk of an untreated seizure or you know non-convulsive status is potentially significant in these brain-injured patients.
Absolutely. Thank you very much. I realize we've gone over time, and so there are so many questions that we will in the chat that people can be answered afterwards. I'm just trying to think. I don't know that there's one that could be simply done. There's questions about steroids and therapeutic hypothermia and even autonomic dysfunction, which I just feel, unfortunately, I think we're not going to have time to answer, but certainly I know that the hosts will allow us to connect afterwards. Thank you very much, Dr. Burgess. That was very enlightening, and I think especially those tools that can be done with focus is very interesting.
Thank you so much for having me, everybody.
Thank you, Dr. Quaz, for this, and Dr. Burgess for this nice presentation. Dr. Rai, do you want to say something or comment?
Yes, my voice is clear.
Yes.
Yes, thank you very much for the speakers and mediators. It is very nice, amazing lecture. I just have a comment on the very nice, amazing presentation of high ICP, especially for our junior intensivist and fellows. Usually it is better to, you know, to like divide the intervention, especially regarding the choice of sedation, that if you want to do intubation for such patient, what is the best medication that you can use? Actually, as it is well known for all senior intensivists that ketamine was initially thought to be contraindicated in high ICP, and to clarify as for junior staff that it is now no more. Actually, it is in the opposite way, that it is neuroprotective and you can use it. So for intubating high ICP patient, you have multiple options, you can use ketamine and benzodiazepine, depending, of course, on the hemodynamic stability of the patient. Propofol is very nice also as pre-medication for intubation. Currently, actually, in the ICU setting, after you intubate and you do the initial very nice neuroprotective measures, I agree about Presidix, dexmedetomidine, that it sometimes really confuse us with the really, I observed commonly we have bradycardia and lower heart rate from the baseline. So maybe the best choices is ketamine with benzo, like midazolam, or fentanyl and midazolam, according
Thank
to
you,
the
Doctor.
blood pressure. Thank you very
Thank
much.
you very much. Okay, so just before I close, there is a special promo code today to get 10% discount when you apply to our Pediatric Critical Care Fellowship. It's written here by the president before the end of this month. Type here, just I would like to thank Dr. Al-Bassam, Dr. Gwans, and helping me to organize this a scientific webinar, and would like to thank Dr. Sayed and Dr. Burgess for those very helpful for us as intensivist and neurologist presentation. And I will just close up in just 1 minute or and a half that neurocritical care or cases is not all the time as a straightforward cases. There is a challenge case, need focus history and physical examination. And there is many tools can help us like EEG, like brain imaging, and we review many children cases presented in this webinar about confused child, not responding child, or sometimes clear encephalopathic picture child with different presentation, challenge presentation, different intervention. And Dr. Burgess also present about the increase in intracranial pressure and why it is immediately or fast intervention is matter, because we are dealing with a very important vital organ. It is the brain, which is impaired insult will affect the quality of life. And so our duty as a intensivist, as a neurologist, to keep this organ intact and as we can, and to try to prevent a secondary injury and to try to improve the primary injury. And by this statement, I'd like to thanks also the attendees for they stay with us 1.5 hours. We schedule for 1 hour, but they stay 1.5 hour, more than 350 trying and discussing and very helpful questions. So by this time, I'd like to thank everybody and we end our scientific webinar. Thank you for all.